Most rehab fails because it skips important steps. We believe rehabilitation shouldn't be a random process. It should be rapid. This is the RAPID Rehabilitation Framework. Whether you're an elite athlete or an everyday client, this is our process. Step 1, we diagnose the problem. Every successful rehab starts with clarity. This includes a clinical assessment with our expert physios. We set expectations and lay out a clear plan. If needed, we refer you for imaging and sports medicine or orthopedic opinion. Then we get to work. We protect the injured tissue and facilitate healing by applying the right load at the right time. We reduce pain and manage inflammation while restoring normal movement and supporting an early return to safe activity. Step 2, initiation. Finding the right entry point to exercise is crucial. This is where we start to develop your capacity. We reintroduce controlled loading, isolate injured tissues, and rebuild movement quality, laying the foundation for everything that follows. We focus on what you can do to stay active and avoid losing fitness and strength. Step 3, progression. This is where we measure and build real strength and power. Load increases, movement varies, power and plyometrics are introduced, preparing the body to absorb and produce high levels of force quickly and with control. Step 4, accumulation. This is where capacity is built for performance in the things you care about. Peak strength, speed, and intensity come together. For some clients, this is where running and early return to sport activities begin. Power and confidence increase, and the body learns to perform consistently under higher demands. Step 5, return to chaos. This is where we restore peak performance. We're no longer focused on the injury, we're focused on performance. The goal is to come back better than you were before your injury. High-speed movement, reactive tasks, and performance under fatigue, building confidence and preparing the body for high performance in the chaos of the real world. Different people, different injuries, the same process. This isn't random. It's the RAPID Rehabilitation Framework.
Okay, so why did we create the RAPID Rehabilitation Framework? Look, I suppose there's loads of reasons why, but there's a right and a wrong way to do things. It's the first thing, and I suppose over 10, 15 years worth of experience, you kind of develop a consistent structure in what you're doing, and the framework is to try and put that out clearly, set it out clearly, to provide a structure, to hold ourselves accountable, to make sure that what we do is we go through a full and thorough, comprehensive progression of rehabilitation, but also to be able to make sure that we have a continuity amongst our team, and then also to be able to explain clearly the plan and the structure for our clients when they come in, that we can say, look, here's where we are today on the roadmap. Here is level 2, here's level 3, and show that there's a plan in place here. And it's also not to be overly prescriptive, because we know we then have to apply it to the individual. So it's a framework. It's not a paint by numbers. It's an outline. It's a plan, making sure that we have a North Star to kind of guide us along the journey. I think that's really the main reason why, it gives us that sense of a target and an expectation.
Yeah, and I mean, it was something we were both doing anyway. We just didn't have, I suppose, a clear definition on it or a clear name on it. There was little things I was doing, little things you were doing. We're like, actually, you know what, let's sit down here. Let's graph it all out. Let's imagine it was a knee injury. Let's imagine it was a shoulder injury. What are the common trends? Obviously we know the diagnosis. What are the common trends around activation or rehab? When is it strength? When is it power? What does sport look like? How does that change from joint to joint? And having this sort of overbearing idea of like, can we apply this now to multiple joints, multiple age groups, multiple sports, and having that framework. And we all know patients, I suppose, who've come into us and they're trying to work on level 5 and they haven't nailed maybe level 1 or 2 yet, or vice versa. People who nail 1, they nail 2 and they jump to 5 and they skip 3 or 4. That education piece, it is invaluable. You can even see it with members or with patients when we explain that to them, that you're looking really, really strong here. Your calf strength is unbelievable, but you can't hop. If you can't hop, how do you expect to sprint?
Yeah.
And if you can't sprint, how do you expect to play a full match or 2 matches in a week? So that education side, showing that to them on the pyramid, telling them how, someone's gone wrong in the past by doing this, or, explaining why they've gone wrong in the past, maybe why rehab has failed them up to now, they've skipped a step, and it's a light bulb moment for them.
Yeah, 100%. And I think the visual of a pyramid structure kind of works really well, because you have to have that kind of wide and stable base, the foundations in the early stages, and that wide and stable base allows you to build this high peak ultimately. So I think that could be a nice reference. And the idea of the pyramid structure is also that, you can't achieve the higher levels until you have nailed the bottom levels. And if I'm ever struggling in those higher levels, it's always because I'm missing something down lower. Have we got our diagnosis right? Have we built enough strength, enough range of motion, enough control for us then to be able to go into those higher levels? So it's always a nice way to circle back then again, to hold ourselves accountable, to make sure that have we got this person good enough at the foundations to then be able to jump, land, hop, skip, or climb the stairs or play golf or whatever it might be. And I think it just provides that nice structure.
And sometimes it's not exciting as either, because, the level 5 stuff, the top of the pyramid looks great. On Instagram, that's brilliant. To the patient, I'm doing this really exciting drill, or I use golfers as the example. They've got the super speed sticks and they're swinging for the hills, but actually they don't rotate well in the first place, or they can barely do a squat or barely do a hinge. So they're skipping so many levels and doing the really fun, really exciting thing, when it's actually the boring, slow, simple, basic thing that they're missing. So as you said, if you haven't ticked the bottom level, you have no right kind of jumping to the top.
Yeah, 100%. So, yeah. Okay, in terms then of, maybe we'll have a little bit of a chat through what our different levels are. So I suppose our first level is D for diagnosis. And look, this is just a fundamental part of, I suppose, of what we do as physiotherapists, and it really sets the scene. And I think getting an accurate diagnosis is just absolutely vital. And what it does is it then sets us up to make sure that everything else that follows is done correctly. So based on our diagnosis, we can then decide what level of activity should we be doing, how heavy should our load be, how many exercises are we doing, what type of exercises are we doing, and we all build from there, and to make sure that what we don't do is underload somebody by taking it too easy, or overload somebody by pushing them harder than they should.
And what are some of those elements of an accurate diagnosis? Like, if I come into you and I've got a problem, be it my knee or my shoulder, what are you doing to diagnose me?
Yeah, the first thing starts with a clinical assessment and a history. And I suppose initially the history is always the most important thing. So we want to have a detailed conversation with you to understand fully what's going on, what's the pattern of this injury, when did it start, was there any incident, or was it more an overload problem? And we want to learn kind of the full background there, so that we can then make a kind of a hypothesis in our head as to what does this injury sound like? What do we think's going on? Do we think muscle is involved? Do we think tendons involved? Do we think bone is involved? And from there then, after our detailed conversation, and we've got that full background, including what the patient's goals are, and what the level of activity they are currently able for, and what's aggravating their pain and their own perception of the injury. And once we have all of that stuff, we can then go ahead and do our clinical assessment, which is a kind of a step-by-step process, where we'll usually first have a look at general movement, see, how is this person able to do basic tasks like a squat on 2 legs or 1 leg? What's their gait like? How are they doing functional tasks like climbing the stairs or bending down to pick something up, depending on their specific injury? Or it could be having a look at their golf swing, or it could be having a look at their weightlifting technique.
Yeah, their range of motion, their strengths. Is this a one joint problem? Is this, I hurt my shoulder lifting something over my head, or, I was sprinting yesterday and I hurt my hamstring. Sometimes it's very quick and easy and simple. Like, okay, it looks like a hamstring strain. It smells like one. And other times, I suppose, it can be really complex. This is, I've had a sore back here for 2.5 years. I've had 4 MRIs, 3 X-rays. I've seen 7 specialists, and I'm not sure what's going on. So, that diagnosis could be really quick and easy. It can take a long time. And, sometimes we do need to go and get an X-ray or get an MRI or see someone else. And I often think as well with the diagnosis, sometimes it is, everyone wants a one-word answer. Everyone wants hip or back or ligament or tendon. And sometimes it is a one-word answer, and sometimes it's not. Sometimes it's, well, do you know what, there's a few factors here that are playing a part. With your back pain, it's a little bit because of this, and this. and let's go after those maybe modifiable factors. So, to get to that really accurate diagnosis, it can take a little bit of work.
Yeah, and I think there's two ways to look at it, and I'll often explain it this way to our clients when we're looking to make a diagnosis. We have our structural diagnosis, and then we have our functional diagnosis. And sometimes one is way more important than the other, okay? In the case of a structural diagnosis, structural diagnoses that are really important are ones that really change what we need to do, such as, have I a fracture? If I have a fracture, we have to allow that bone to heal. We have to pull back. But if I have something a little bit more non-specific, and maybe I just have some overloaded tissue, well, then the structure is less important. And what's really important then is the function. And to be honest, the function is always really important, because that's the thing that we can really modify and change, I suppose, with what we do. And we can be very detailed in looking at the structure, and we can also be very detailed in looking at the function. If we want to be detailed looking at structure, it'll often involve further investigations, x-rays, MRI scans, CT scans, ultrasound, and maybe onward referral to experts who can give us clear guidance on the structure. And then when it comes to the functional piece, that involves, as you mentioned earlier, looking at range of motion, looking at how well somebody controls their body when they move, having a look at their muscle strength, muscle control. And there's a huge amount of detail around that that I think is very person specific and sports specific. And that's what we will spend a huge amount of time on, I suppose, in that early phase. So that ideally at the end of that kind of initial session, we have learned the full background story about what's going on here and all the contributing factors. Yeah. We've decided whether or not we need to isolate any structural diagnosis here, and organised referrals and onward opinions from specialists if required. And then we've got a really clear understanding of what the functional diagnosis here, what are the deficits that this person has that are contributing to the problem.
How important is it that the person themselves knows leaving here what their diagnosis is, or what you're diagnosing them as, and what you think the plan forward for them is, be it their expected timelines, or be it what they need to focus on first, the elephant in the room, what they need to improve?
Yeah, look, I think it's probably the most important thing ultimately. There's no point in me having this clear sense in my head and the person is confused and the person feels lost and maybe the person is worried and fearful. So it's trying to make sure that along the journey, we're building a partnership here with our clients all the time. And it can't be a one-way street. So it has to be a case of us understanding it together. And I think when things are going really well, it's a journey of discovery. We're discovering what's going on, and while the client with us is also discovering what's going on, and we're learning together. And there's a two-way feedback there on that in regards to a conversation, but also in regards constantly during our assessment. As we assess your movement, as we assess your strength, how does that feel? Do you think that's important? Does that link to your problem? And those conversations that are back and forth are often the real detail here as to how we get buy-in and how we understand and the person understands. And I always think it's an important thing to go and check with okay, so tell me what you learned today, or tell me what your sense of what's going on is now,
But even this week, I had somebody on I think Monday or Tuesday, and I was crystal clear on what their biggest problem was. I think it was their third session, and we were clearly working on one thing. It was their knee extension strength, their quad. And when they came back and it was getting better, but it wasn't perfect, and they still had this one thing that was improving, not a little bit with to go. And I asked them, I go, what's the biggest thing they're working on? And they didn't have a clue. And I said, we've been through this, think about what of everything. I pulled up their 3 programs to date, and I said, what are we working on all these programs? Oh, we're working on the, it just wasn't a one-word answer. So I made sure leaving that appointment that they were crystal clear. And, we almost have to remind ourselves at times that we might think we said it, whether they've understood it, whether they can say it back to us. It's so important.
Absolutely. And I think we have to be humble in regard to the fact that we don't want to speak using jargon terms when we're dealing with our clients. And we also want to make sure that we do simplify it. And as you say, I think quite often we can maybe we can go into detail that sometimes can be lost. So it is important that we always bring it back to that simple idea of what are you taking from today, and what are the main goals, and what are the things you need to work on. And absolutely, Mike, I think it's something that clinicians, including ourselves, should always do, is double check the understanding. Are we on the same page here? Have we got that sense of shared understanding as to what's going on? Just one other thing on the diagnosis piece, I suppose, is that we have to also be, I think, understanding and I suppose humble in the fact that our clinical assessment can't always isolate structural injuries. And, while our clinical assessment is brilliant at creating a sense of what the functional problem is, the person's strength, the person's power, and also can get a good sense of what the structural injury is. It's not perfect at that. And a good example of this will be things like muscle strains. And it's something that I think has really evolved in physiotherapy practice over the last few years, where, you rewind 10 years ago, a muscle strain was at best a grade 1 or grade 2 or grade 3. Now we have a totally different way of thinking about it. We now want to know what actual structure is injured here. Have we got muscle injured? Have we got tendon injured? What part of the tendon is injured? And we know that our clinical assessment techniques can't fully find that out. So we need to refer for imaging if we want to be very specific around that. And I think that's a really important part. Again, we've probably all been caught thinking, oh, this looks like a low grade strain. And then, okay, we go and organise a scan and realise actually there's a tendon involvement here and it's higher grade. And that's because some of those injuries are just a little bit sneaky in the way they present. They can feel fine when I'm lying on the bed. They can feel fine when I'm walking around. And these are often the ones then that people get caught with, where, geez, everything felt grand when I was doing all of this slow, easy stuff in the gym and slow and easy stuff on the physio bed. And then actually I went back running and, even jogging was okay. But when I went to sprint, I got caught. And that's because we didn't have the diagnosis right. And I can only just think of a slightly separate example there recently, where I had a client coming in, he's a distance runner and had a history of, previous stress fractures, and came in to me saying, listen, I've pulled my calf. Really certain he's pulled his calf. Kind of, that's what it felt like. He's had a low grade calf strain before, and we assessed it. And, listening to his story, he had ran on it, got some pain, gave it a week to rest, ran on it again, got pain again. And then he did some soft tissue work himself, like he got the massage going out, and it was around his lateral calf. And that made him way worse. He was really sore after the soft tissue work. When I assessed him and we palpate through the area, he did actually have a low-grade calf strain, but he also had a fibular stress fracture. And it's so easy to miss these things because, he says it's a calf injury. It kind of looks and smells like a calf injury, but only when we really dig into it and, listen carefully to his story, and also pay close attention to where his pain is and how it feels when we palpate that bone, and then we follow that up with a scan, we realize this guy has a stress fracture. We actually have to pull back here, and we can't treat it in the way we would normally treat a calf injury. And that saves huge time for people too, because you just don't want to be the clinician who is, bringing someone around the roundabout of this is a calf strain when actually it's a stress fracture. And it's so I think that again just explains that reason why it's so important for us to get the diagnosis right.
Big time. And I think as part of that diagnosis, part of that plan, sometimes we can have the one word answer there, which is stress fracture or calf strain. But really, we've all the factors that led to that. I often call it finding the root cause. It's like, okay, you're coming into me with your 4th calf strain in a row. It's easy to just say, let's rehab the calf. But really, this could be a load management issue that you're doing far too much running. This could be a strength issue, you're not generally strength training. This could be an asymmetry issue that maybe your other leg is weak, or your knee isn't doing its job, and when you're running, there's not enough coming from your quad, not enough from your glute, and it's all coming from your calf. This could be, I'm not sleeping, I'm not recovering, I'm not eating enough. And, while we often want a one word, one joint, simple answer, I often say it's like a pie chart. And on that pie chart, we've got really big segments, the elephant in the room. The huge thing here is, okay, your calf's at you. But we've all these little contributing factors, they're all adding up. And, the more I think we can think maybe holistically, or the more we can start to challenge some of these other things, or even just highlight them. This might be new information to the runner who didn't know that they ramped their mileage too quickly after their holiday, or they didn't know that, actually I need to sleep and eat more and whatever else it is. So there's all these factors that lead us to the injury. What's the root cause? I see it with my golfers all the time. They have a low back pain, and the golf low back pain from rotating can be completely different than the low back pain I get in the garden picking something up. And it's a little bit my hip could be more mobile, it's a little bit my shoulder could be more mobile, it's a little bit I need to sit back, and it's a little bit that I shouldn't hit 150 balls on the driving range the day before round. So if you can get all these factors right, I think that's where you can get a huge win with patients. And maybe you earlier on in your career it was hard to spot how all these things can add up. And you're touching on something there that's so important. It's that idea of the broader context, and as you mentioned there, actually in that specific story there about his client with the stress fracture, he'd had a previous stress fracture, and he'd gone to a dietitian and done loads of hard work on trying to improve the factors that we know are associated with sort of bone stress injuries. So it was kind of hard for him to hear again that he had a bone stress injury. But when we drilled into it, he's got a newborn baby,
and sleep's not good, of course, and we can often just maybe miss these things that are there. That if I'm suddenly sleeping 4 or 5 hours a night and I'm still training at a high load, well, look, my body just can't recover as well. And I think that's where the kind of detective work and the kind of rapport and the relationship you build with your client is so important, that you're trying to get access to this information that sometimes takes a while to kind of for the full story to come out as well, and it can be difficult. And I think a few key questions I think that we always need to ask are, how's your sleep? Because it usually is a good marker for how are you stressed, or how much stress have you going on, like if and how busy you are, and maybe what else is happening in your life. So I think asking those questions around sleep and around stress and around kind of life load, is there any big life events happening at the moment, which of course can be an impact on how our body recovers and how I feel. So definitely I think really, really important.
Okay, we have our diagnosis. We know let's imagine it's my knee. We know there's something going on here at my knee. I can't run at the moment. I can't squat at the moment. Is that it? Like, is there anything I can do, as part of this diagnosis level on our rehabilitation framework? Are we looking at anything else? Are we, the idea of let's not detrain, let's not decondition at the same time?
Well, Mike, you said it there, is there anything I can do?
Yeah.
And that's something that I think is exactly the way I would frame it. Let's find out what we can do, not what we can't do here in this early phase. Well, yes, we have to protect the injured tissue. There's loads we can do. We can start by priming your recovery, by giving you advice around the importance of sleep, the importance of nutrition, the importance of stress management. We can also start to exercise the non-injured areas. Begin by loading those muscle groups. So if you have a lower limb injury, can we load the other limb, and can we load your upper body? Can we also get you started on an aerobic program to start working on your conditioning? And I think there's a huge part there, which it can be a big mindset shift, because so often what happens is, I get injured and the rug gets pulled from underneath me, and I now can't do the things I enjoy. And that can have a real effect on our mood and our sort of sense of self as well, a little bit, where, I can't do the things that I identify with. And it's I think a huge part of it is kind of helping people gain control over that again and get back doing things that, we start feel like we're moving in the right direction. And of course, aerobic training helps my recovery. Certainly it's important for my overall health, and it's usually important if I'm involved in any sport that we start building a base there. So what we don't want is that our injury is this kind of, reason why everything falls off the wagon. We want to be much more proactive than that if we can. As I said, oftentimes like framing it early as our goal here is to come back better than we ever were. So we need to start that now. What are the things we can work on? What are the things we can improve? And I think that's a really powerful framing, and people often leave, I think, energized by that idea when we've mapped that out. And it is important to spend time on that early on.
Yeah, it's that idea of can I make plan B as close to plan A as possible? And like we've both been there, right? We've both played sport our whole life. You get injured when you're fit, you're giving out about training on a wet, cold, night in November, and you're saying, "Oh, geez, I'd love to be staying at home right now, cozy at home." And the second you're injured and you can't do it, that's where you want to be. So it's a huge part of the athletes come into us, or even the older person playing a bit of golf or going for their walk with their friends. It's a huge part of your life, and when you can't do it, as you said, the mood can drop a bit. So having this really sort of global, all-encompassing plan of, okay, let's not do this, this, and this, but let's definitely do all of this, I think can really help the athlete. And I'm huge on the sort of the science behind this detraining and this deconditioning. And if I'm an athlete and I've spent 15 years building my aerobic base, and the second something's injured, I just do nothing, well, I'm going to start to detrain, at a reasonable rate. Or if it's strength and power training, if my knee's at me and I just say, well, I'm not going to the gym if I can't do everything, I'm going to lose that muscle mass, that power, that strength, again, quicker than I'd like. So, let's lose as little as possible. So if I drop a little bit and, we fix the problem knee, I'm coming up from an okay base. Whereas if I let that fall off a cliff, I've a bigger stairs to climb.
Yeah, 100%. And, it's simply like, don't stop. We don't want to stop our activity levels. We don't want to stop training. We want to change our training, adapt our training to suit our needs right now. And that's what we can help people with as physios, but we don't stop. And that's a really important thing. And I think that can be a mindset shift for people, which is really important. Hugely important part of the sort of diagnosis phase is pain management. And, it's one of the most important things for clients and for us too, is that we help people get on top of pain. What works for you, Mike?
It can depend on what the injury is, what the diagnosis is. So, the old sort of RICE, or now it's the police protocol. Do we need to protect this site? If I've rolled my ankle, or I might have had a fracture. Do I need to offload it? Do I need to tape it? Do I need to mind it? Do I need to go into a sling for my shoulder? Is there a lot of swelling? Does it need ice, or is it well left alone? Do I need anti-inflammatories? Do I need painkillers? Do I need to sort of offload or protect? That can help. Sometimes actually by doing our initiation, which we'll get to now in a minute, but sometimes by starting my exercises, that can really help for my pain. You know, if this long-standing knee pain when I walk down the stairs and my knee goes forward is difficult, and my quad is really weak, and sometimes I give someone a quad exercise or a knee exercise and they feel really good after, I say, well, actually, that's your painkiller. This exercise is your painkiller. You're going to feel better after you doing this, more so than after taking your anti-inflammatories. But, you know, we're trying to get to, I suppose, what kind of pain is this person coming in with? Is this a bog standard muscular pain? You know, is this a tendon pain? Is this a bone pain? Is this some sort of neuropathic pain? Or is this, you know, something way more complex, a more centralized pain, or, you know, a complex kind of pain presentation? So, you know, it's part of our accurate diagnosis is to figure out, is there a structure involved here? Is there a particular type of pain involved here? Have I seen this in the past and I know I can help them, be it with modalities, be it with ice, be it with electrotherapy, be it with medication, be it with exercise? How can I get that person feeling better? And if you can get that person feeling better, you know, within that first session or ASAP, you know, they're going to really trust you, and they're going to hopefully follow the plan from here on out to get back to where they want to go.
Yeah, no, spot on. And I think it's such an important area. And I think, you know, the kind of the management of pain in kind of the physio world has progressed quite a bit. You mentioned we have our RICE protocol. And I think a lot of people are still stuck on the RICE protocol. You still hear it mentioned a lot. And then you have your police protocol, and, you know, even more recently you have your peace and love protocol. And it's just been really interesting to see how that actually develops over time. And
I think they developed that in Woodstock.
Yeah, I like the name of it. But I think, there's so many areas to this. And I think in the clinic here, you know, a huge part of what we do, I suppose, around pain management is advising people, first of all, advising people to maybe avoid things that aggravate them, try and help them identify the things that aggravate their pain, whether that's an activity or maybe a total amount of load, or, you know, how frequently they're doing things, and to open up the door to ways to create the conditions for them to feel less pain, which often is focusing on things like recovery, you know, optimizing sleep, getting their nutrition right, managing stress, and just taking some relative rest away from, you know, stressors that may be activity related, or it could be more life related. And alongside that, it's exercising the body in a way that is therapeutic. So it's showing someone exercises and movement that helps their pain. And again, that can be very simple, and sometimes it's a little bit more in depth and complex. And that our skills there and exercise selection are really, really important. And you know, why does exercise help? Well, I suppose we get increase in blood flow. We get you know, warming up of that tissue. We often get we get pain inhibition often, and when we exercise, we can fire those muscles up a little bit better. They become less inhibited and then start to function a bit better, which can often make the joints that the muscles surround feel a lot better. And we also get a greater sense of, you know, self-efficacy. I can actually do this, and maybe I've been avoiding this for a long time. And, you know, our bodies are built to move. We're healthiest and happiest when we're mobile, when we're active. So if we are inactive, while we can sometimes be using that as a coping strategy to reduce pain, ultimately getting you back active and moving is really important for reducing your levels of pain and restoring your function. So I think they're all really important. And then our skill set as manual therapists can come in here a lot, whereby we can facilitate people moving better and feeling better with some hands-on therapy. That can be some soft tissue work, sometimes some joint mobilizations. So this can include, you know, massage work or mobilizing a joint. And I really like to combine this with exercise so that we use the soft tissue based work to facilitate giving someone exercise that also makes them feel better. Because I think it's always about empowering people to be able to make themselves better, rather than having it too much so that they need someone else to make them feel better.
Yeah.
I think that's really important.
And I think, though, we almost need to check ourselves on this pain side of things, that this can be really, really scary for the person in front of you. And, you know, while we might have seen 1,000 shoulders and 1,000 knees, you know, this person's coming in, they're not booking into us for a laugh. They're booking into us because this sore knee is actually really affecting their life. And maybe they're really, really worried about this, and they might have seen a couple of people before us, and they have a neighbour who had a bad knee and couldn't play golf anymore. And now maybe their own sense of community or sense of, I suppose, normal everyday activity is being affected here. So this can be scary. It can be worrying. They're not booking into us. And again, for like our diagnosis might be weak rotator cuff and asymmetrical loading during certain exercises, but they're not coming in saying that. They're not saying, Risteard, I think I have a weak rotator cuff and asymmetrical loading. They're saying that I've pain in my shoulder. And pain is the main driver. Pain and injury are the drivers of people booking in. And we don't want to gloss over that and ignore that and just jump straight into this, what you need to do. It's what actually explain the pain, explain why it's there, show them this movement's sore, this one isn't, or that one isn't.
Yeah.
We'll get to that initiation phase in a minute, but, hopefully if we can initiate the right exercise or the right protocol or the right pain management and they feel better, that's relief, that's fear dying down. That's maybe I will get back playing tennis with my friends and go for a coffee afterwards because I'm really meaning that, I'm really missing that. Or maybe that is I can get back on the pitch and play GAA or rugby or soccer or whatever it is, That's my group and I've been training for years and the big final's coming up. So we can't gloss over that pain side because that's often the biggest thing that they come in saying to us.
Absolutely. And I think an important thing to always try and help people with is, first of all, just empathize with them and to listen to them and to validate the feeling around pain that they have and to acknowledge the stress that can come with that and the impact that can have on someone's quality of life as well as their identity and their ability to do what they want to do. I think that's really important, absolutely. And I think, there's probably, different ways in which we deal with pain and maybe different types of pain that are really, really important, as you touched on all the different types of pain. And one of the important areas, I think, for us is trying to help people understand what their pain means. Does this pain mean that you need to stop? Does this pain mean that that every time you do this thing, you're damaging yourself? And quite often, pain doesn't mean I need to stop. And it doesn't mean that pain does not equal damage. They don't mean the same thing, but there of course can be a relationship, and is a relationship between pain and injury, but they are not one and the same. So sometimes we have pain that is trying to protect us, and it is guiding us maybe to become less active and to change our behavior. And part of us is to try and work with that pain to help people try and find a way forward and find a way to improve and, of course, reduce that pain and improve it. And depending on the length that the pain has been there, etc., there can be a very different meaning behind the pain. And, it's a detailed area that we will often spend a huge amount of time with our clients. And I think one of the things we have expertise in is dealing with those maybe more complex pain scenarios. And, it's probably for another chat to go into the details of it, but it's certainly an area that is, it's really important, I think, for people in persistent or chronic pain that they're listened to and that they're heard and that they have a support there from therapists that can help them. And certainly something that we enjoy working with and that we can often see big progress with.
So, Risteard, we have our diagnosis. What next?
So next we go into our initiation phase, and this is where we look to sort of isolate the injured tissues and begin to load them. In some cases, it may be involved. There's a longer rest period. For example, if we have a fracture, but if we're talking about muscle injuries, and I suppose most musculoskeletal injuries, we're starting to exercise early, and we know that getting involved in loading the body at the appropriate level, loading the injured tissue at the appropriate level is massively important for restoring function and for facilitating healing. So I think in this phase, the most important piece is getting the entry level right. Where exactly do I start? And, I can think of particular when I treat shoulders, you'll see lots of people might come in and maybe the arm's been hanging down by the side, and they haven't been able to use it much in maybe a couple of months. And it's very painful if they've maybe got rotator cuff related pain or shoulder stiffness, for example. And it can be really transformative if we choose the right exercise and suddenly the shoulders beginning to move more comfortably. And after doing the exercise, all of a sudden there's a lightness to the arm. It feels easier. And all of a sudden there's a step in the right direction, and there's a sense of, okay, I know what's going on, and now I'm starting to believe that I can actually get better. And so I think that entry level piece is really important, and there's a lot of nuance to it, Mike, I think. So
yeah, and I think if you get that right though, it re-emphasizes your diagnosis.
Yeah.
So if you're telling the patient in front of you, I think the problem is this,
yeah,
and here's the first exercise I'm going to give you to fix it.
Yeah.
And straight away they feel better.
Yeah.
Well, they're like, actually, Risteard has probably got the right problem and the right solution here. So there's that buy-in, there's that belief.
Yeah.
And for you yourself, you're no longer thinking it could be something else.
Yeah.
And I think the second thing there is that puts recovery in the patient's hands.
Yeah.
And again, I have 2 people in this week with a fracture. And the hardest thing about that for the 2 of them is there's nothing they can do to make this better right now. They've got to offload that area. They've got to be nice. They've got to let that bone heal. They would love if I said, hop on the bike for 4 hours and your bone will improve. They would love to have that control, but they don't. They have to stay on their crutch, or they have to stay on their sling, or whatever it is. They have to let that tissue heal. Whereas if it is this musculoskeletal issue and they do exercise X and they feel way better, now it's like, okay, I'm actually in control here.
This initiation phase is a real, it's one step past the diagnosis phase, because you touched on it there. It's that idea of shared discovery again. And when things are going well, we've gone through our assessment. We've looked at range of motion, and then based off that, we've looked at range of motion. We've looked at movement control. We've looked at strength. And based off that, we've decided this exercise with this amount of load at this angle for this many reps is going to change how this tissue feels. And then when I do that and all of a sudden I feel better, as you said, it's this feedback loop where the person starts to gain a self-efficacy. It backs up what we found in our assessment. And I think it can be a really powerful light switch moment where it's, okay, we're moving in the right direction. It all makes sense now. So yeah, I think that's really important.
And I think we can almost gloss over what you said there, right? But this is the thing that separates, I suppose, really experienced clinicians who can really help people with everyone else. And that's the right exercise at the right load, at the right angle, for the right amount of reps, for the right frequency.
Yeah.
Because a lot of people can say, okay, they need a stronger quad for their knee extension, or it's a rotator cuff related pain, or it's, whatever for my lower back or my glute. It's very, I think not 9 out of 10 physios will find the right problem, but they won't often find that right solution, which is they might start them on something too difficult or too easy, or I suppose we might, let's say for an Achilles, if my granny can do 10 calf raises, that might be enough for, okay, but for the athlete who wants to run a marathon, maybe it's not enough for them. So having that context of what's good enough for this person, or what can the other side do? And, even the person coming into you can say, well, I think it's my rotator cuff, Risteard. And you'll go, well, I agree with you, but what you're doing in the gym is way too hard or way too easy, or it doesn't correlate to actually where I find your weakness, find your pain. So, it's actually, it's the experience you have seeing thousands of shoulders that allows you to really accurately and really quickly get to that right solution.
Yeah. And I think it's, we don't want to overcomplicate the idea, because sometimes it's extremely simple. Sometimes it's a very basic movement, a very, very basic exercise. And sometimes it isn't. Sometimes we have to be very precise. We have to be very particular about the way we do things. And again, as you said, Mike, it's that experience. And I think what as physios and strength and conditioning coaches, which we are exercise experts. And the really, as you said there, I think that really sets clinicians apart is that ability to find the right entry point.
Yeah.
To be able to maybe progress or regress the exercise appropriately. And to be honest with you, I think we'll probably all agree that like what most people will do is come in too hot, come in too hard, and I think, maybe what we do is sometimes we might fall into a sense of, oh, this is what I did before, so it worked, but we have to apply it to the individual, and we have to be flexible in the way we prescribe exercise. And again, quite often it is simple, but sometimes we have to be really particular about the position, the angle, the load, the speed. And small, subtle changes there can make all the difference, where, suddenly that feels much better now. And that's the coaching side of things. It's the cueing side of things. And I think we have to be really switched on in that early phase to create buy-in, because there is a bit of jeopardy there. If we come in, way outside what's going to work here, how many times can we do that before we begin to lose the trust and the relationship at the beginning? So it is really about finding that right level and building trust with our client.
Yeah, and again, on the initiation, like as you said, somebody might have said, well, I tried 3 rotator cuff exercises and my shoulder was killing me for a week. And then they almost go the opposite way. They flip and then they do nothing. And then I did nothing for 3 weeks and it's still sore. Yeah. So they either go in way too hot, or they do absolutely nothing.
Yeah.
They rest it, they lie down, I'll take a break for a month. And there can be a little bit of fear when we're starting something. It's like, I'm not booking in with your Risteard because this shoulder feels great.
Yeah.
I'm booking in with you because this is actually really sore and it's really affecting me. And now I can't sleep and I'm struggling to put things overhead at home. So, there can be a little bit of fear about starting something new, especially something that sounds like the thing that actually annoyed me in the past. But when you get that right level, it's up from rest and they feel better. That, it's a huge buy-in, it's a huge relief.
Yeah.
They're worried, geez, do I need more MRIs? Do I need a surgery here?
Yeah.
Is this the same bad shoulder that my uncle had and then he couldn't work? So the second they see that, I suppose, that positive change, it can be like, oh, phew, thank God, I only have 2 shoulders. Risteard's seen 1,000, he can really help me here.
Yeah.
And even on the mechanisms, it's like, the second my brain starts working that area and sending the signal, and I get some of that motor unit recruitment, some of that activation, geez, my strength has improved loads in 30 seconds. It can happen quick. And even from, my heart is now pumping blood to that area. Any recovery or any tissue damage might get a bit better with more blood supply and more oxygen to the area. So, if we can get that motor unit recruitment, we can get that heart pumping, we can get that person's fear to die down, we can re-emphasize our diagnosis. Like, not only have we initiated the rehab, maybe we've reinitiated, that spark of, I can get better. There is maybe a light at the end of the tunnel.
Brilliant, Mike. And look, you're touching on this idea of it's how we package the exercise. It's not just try this. It's we're doing this because, why are we doing this? Why do I think this is going to work? And there needs to be a logic there that we can, a strong logic based on our assessment. That we're not choosing exercise. We're not giving this a go because it might help. We're doing it because this is exactly what you need. This is why you need it. And then the next thing is, this is how we start. This is the first step. And then the next thing that's really important is explaining this is where you need to go. And, I can just think of so many examples where you might see someone who, just take shoulder, for example. I tend to see quite a few who have maybe had an issue that's there for quite a long time. And maybe they've seen physio before and they've also tried exercise before and it didn't help. And I'm there saying to them, well, listen, what you need to do is you need to rehabilitate the shoulder with exercise is a big part of what you need to do. So it's really important that we need to get the details of that right. So we're going to do it differently. We're going to explain exactly why you need to do it. We're going to explain exactly how to do it. We're going to talk about the details of what you should feel, how do you know it's going wrong? What changes do you make if you're not feeling right? How do you know that it feels right? Where should you feel it? And what are the goals? And all of that kind of packaging around it, I think, is massively important because it creates meaning behind what we're doing. And it's not about 10 exercises. Like, I like to give 2 or 3 exercises if I can. I think when things are going well, you've picked a really important couple of things that are going to move the needle, that are really going to help. And especially in that early phase, if we can get that going, we move a little bit away from pain, a bit closer towards our goals. We're setting the foundation then for our next phase. So this initiation phase we're talking about here, it's just so important. It's really important for builds on on what's going to come. And, we're doing things like building strength in the muscles that have been injured, building motor control, trying to break down any maybe compensatory patterns that people have developed. And all of these things are really important for what we're going to do later on, which is some of the heavier loading and the more sport specific or real world related movements. So this phase can sometimes, seem a little tedious or seem a little bit maybe even boring because the exercises are a little bit more precise and they're a little bit lower intensity. But when we package it correctly and we explain why we're doing this and explain the logic behind it and how it's a stepping stone for the next level.
You're laying those foundations. So, you want to build a house, you appreciate that half the time is spent getting the groundwork right so that the thing can shoot up. And, that's what you do in your rehab.
Yeah.
But again, brilliant, right? Everything you said there, I'm like, great, I want to book in with you now for my shoulder. We're getting the plan and the diagnose and all this, but how do you make it really easy for the patient not to go wrong? Okay, they've been to a physio in the past, they've tried exercise in the past, something's gone wrong. Like what? Like I leave here. You've just done my appointment. I leave here. Like how do you make it fail proof for me?
Yeah. Well, again, I think this is where the kind of partnership piece comes in. So first of all, I think I asked the questions. Do you think you can do this exercise? Do you think this exercise is going to work? Do you understand why you're doing it? And if I'm getting yes, I really like this, I'm looking forward to doing this, then I've got a high confidence. Whereas if there's a little bit of, I'm actually not sure this one feels right, or I don't have confidence doing it, well, we might review it, modify it, change it. And then, of course, what we do with every client with every exercise is we will video record it, and I will narrate the video recording. So I will show the patient the exercise. I will get them to do it, and then I will narrate the video. I will record a video of them doing it and narrate them doing it, and make sure that we say all the key coaching points, and maybe give here's how to modify it, here's how to change it if needed. So there's a bit of, again, this is the idea of packaging the exercise, So and then we put this into a program, of course, where we explain exactly how often am I doing it. We call this the recipe, So we've got our exercises are our ingredients, but it's hard to bake a cake with just the ingredients. We need to know how much of each ingredient do I put in. So at what level do I have to weigh my flour before I put it in. Okay, I don't want to put all the sugar in at the end. Okay, so what I need to do is I need to pick.
I've done that before.
The right amount of the right exercise at the right time. And there's usually 3 things I want my clients to know about these initial exercises. You need to know what to do it. You need to know what to do. Okay, so how exactly to do the exercise, and that's really important. And the videos really help with that, and the coaching helps with that. You need to know when to do it. So are we going to do this twice a day, or are we going to do this every second day? And that's really important because we don't want to underload or overload. The third thing you need to know is, how do I progress this? So there's no point in doing exercise. I'm not just doing something. I'm trying to get better at it. That's the whole point. So if we have those 3 things right, I think that equals a high level of confidence for clients, and
brilliant,
and generally works well.
Yeah, and I love to give people as well maybe a range of things. So I can say, on this exercise, do between 10 and 20 reps. And what I'm not saying is 20 is better than 10. What I'm actually saying here is, we don't know how you'll respond at the start because this is new. So let's dip our toe in the water and see how you feel for the next 24 hours. Let's not dive in head first.
Yeah.
If we all know this is a calf issue, but I'm probably not going to get you to go skipping for an hour straight away, because that would just be diving in at the deep end.
Yeah.
So when you give someone a range and you tell them, right, let's start at this smaller part, but as the week or the 2 weeks, 3 weeks, whatever it is, go on, I want you to go up and up and up and up and up. As long as you're feeling good, not having any exacerbation, it's not causing a flare up, you're getting more confident. And then they're coming back, and it probably ties us into, later on, but they're starting to accumulate a little bit more, maybe tolerance to this exercise. They're starting to hopefully see an improvement day to day. They're coming back better. So they're not just on this one sort of linear line. They're actually getting better as they come on. And by the time you see them, then they're ready for the next step.
Yeah. Spot on. And, quite often, again, it's not maybe always the case that we're looking to 100% avoid all pain, but in general, we want the exercise to be pain-free and feel tiring. If you feel good doing it, you feel tired doing it, and maybe you have some fatigue the next day, but you don't have a big increase in your pain, that's probably a good sense that we're in the right place here. And then, okay, let's try repeat that and then start progressing it. And that's kind of practically what we're aiming for, is ideally pain-free, ideally tiring, and ideally I can do more of it, gradually.
Yeah. And as you said, they have their plan, they know their expectations. So, something I might say is, you're not going to get better twice as quick by doing twice as much. Okay, if anything, that'll make you worse.
Yeah.
So, I don't want you doing this 10 times a day. I don't want you doing it morning, noon and night. I want you sticking to every second day or twice a day, whatever it is. So again, once they're crystal clear on that plan, and I think giving them the example of how this will go wrong. This will go wrong if you don't stop running like I've asked, or if you do way too much. And then they go, oh yeah, phew, I won't do that, because we've all done it. We've all done it ourselves.
Yep.
The 1st of January, I run a 5K every day, and I'm sore by the first weekend. So
yeah.
That happens.
So I think, Mike, it's really important to explain that, because, of course, when we experience the exercise is improving me, well, then there's a kind of a natural logic there. Well, let's do more of it. And a really important sentence I try to always say is, it's not the more you do, the better you get. Okay, there is a Goldilocks zone here. Okay, not too little, not too much, and that's what we need to try and find. And we've all been caught by doing too much, and there's a double-edged sword there where we need to try and find that right level. Okay, and I think that's really important, and explaining that to patients is important, because people do get a bit carried away sometimes and decide, right, we're going to go, this is making me feel better, let's do it 2 or 3 times a day, and then later in the week we're starting to feel sore, and then we're so it's controlling all of those expectations and setting out a really clear plan. Yeah.
And it can build up, and it's like, it can be the rate, right? So it's like, I've gone from doing nothing, I'm absolutely buzzing because I'm leaving here and Risteard's giving me a plan, and I up it for 5 days in a row. And now actually by the following Monday, I'm doing so much more than I was on the previous Monday. And that rate of change is just so high and so sharp that they go, oh no, I broke down after 5 days. So then building in our rest day, or maybe forcing them to have maybe a slower rate of sort of accumulation or of progression, as opposed to a really steep rate. Yes. And again, that can be new information to someone, because like that, they'll say the first 4 days were brilliant. So I kept upping it and kept upping it and kept upping it. And I say, like, well, if you just tried to run to Donegal at some point you'd break down. So, at some point it's too much.
Yeah.
So we're trying to find that zone of safety, that Goldilocks zone.
Brilliant, Mike. And again, it's another really important thing I think always to explain early on is that it's the importance of recovery and it's the importance of rest. So, and I think this crystallizes it, which is that exercise does not make you fit. It makes you tired first.
Yeah.
Okay. So, after your exercise, are you fit and strong now? No, you're now tired and you've fatigued the tissue. So now what you need to do is you need to recover first and then you will get fitter and stronger. And it's really important. So, because again, people do miss this, I think sometimes, which is, I'm just going to go and do more and more and more. And, sometimes that actually can be the root of the problem, which is that, I'm doing a lot, but actually I'm doing too much. So exercise, again, it's tongue in cheek, but exercise doesn't make me fit first. It makes me tired. And then I become fit when I recover from it. And I think that's a really important sort of way of putting it to our clients.
Yeah, and it just reminds me again, someone on Monday, and we might even bring up the kind of the graph of super compensation, okay, which it's actually our theory of if I actually do 1,000 squats, what I do is I get weaker, I get more tired, I get more fatigued, I cause damage, and my body sends a signal there. It's looking for equilibrium and it says, hang on, let's build this back. And what it does is it overshoots. It builds it back better than it was before. And if I can hit my next session when I'm stronger, and I can repeat that over time, the theory is I will get better. Whereas if I'm tired and I haven't quite got back or got above baseline, I hit my next session and I do that over time, I'm going down. And I had someone in during the week who's probably more into, say, bodybuilding style workout, like really big, strong man, but hammering the gym 6 days a week and, 4 or 5 of those days doing lots of upper body work, coming into me with a little bit of an overuse rotator cuff problem, kind of neck pain and stiffness, went on holidays for a week and did nothing and felt great. And, on my diagnosis, on my initiation, yes, I can do a neck exercise. Yes, I can do a rotator cuff exercise. But this man is going to be back to me again and again and again and again and again if we can't tackle the root problem here, which is that the load is really, really, really high. The recovery is a little bit poor, and this can't be outworked or, what somebody like this wants is give me more to make this better. And really what they need to do is a little bit less. And when we went into and this is, I suppose our unique skills as S&C coaches as much as physios is, well, show me your upper body workout. And suddenly now there's 8, 10, 12 upper body exercises per day. They're all extremely high volume. They're all extremely high loads. That was a recipe for this overuse type pain. And, we can't quite outwork it.
100%. No, really, really good.
We have our diagnosis. Brilliant. We've initiated the plan. We're starting to load that area. We're starting to train around the area. We're starting to tackle some of the other contributing factors as to why did we end up with this injury in the first place. Okay, this might even be maybe my second session or my third session at this stage. I'm coming back to you. What am I expecting next? Like, what's the next stage in our rehabilitation framework?
Yeah, so we shift now into phase 3, which is all about progression. So it's about, we started that initial isolated loading of the injured area. So if I have a knee issue, we've been loading our quads in positions where it's comfortable, where the knee can tolerate it. If it's my shoulder, we've been doing some rotator cuff based work in a way that's comfortable and is not aggravating pain. And I suppose we're now beginning to move away from the idea of being worried about pain and more thinking about overall limb function. So for example, if it's a knee issue, we're now starting to move the whole limb. So that might be squat type movements, progressing from maybe double into single leg. We're using different modes of contraction, which means we might be going slow on the way down and, emphasizing the lengthening phases. We might be progressing the load now. So we're starting to set some targets around building strength of the whole limb rather than just isolated muscles. So, can I push? Can I pull?
So my compound work.
My compound work, 100%. So using the whole limb, yeah. And we're looking to build heavier loads gradually. We will start to do some testing in this phase. So we may have already done some testing in the initial phases, but we're looking to really, see progress here in our testing scores and retest and progress on. We also initiate some of the plyometric parts here. So in the progression phase, we shift into plyometrics. We progress to plyometrics, and that involves some faster movement. So we're looking at landing, we're looking at hopping, we're looking at jumping, our ability to decelerate and accelerate. So we're building strength, but now we're starting to do that a little bit faster. We're not at our peak levels. There's still control over what we're doing. We're still protecting the injured site to some degree. We haven't yet, let the shackles off completely. Quite commonly in this phase, we might have decent deficits in strength. So we might be 20, 30, 40% weaker than where we want to be at this moment. So we're loading at a level that's appropriate for us, but it's progressive and it's beginning to feel more like normal training. Yeah. And we're stepping away from the injury kind of idea and more into, a lot more time spent in the gym, certainly in the gym at this stage, and starting to think about tying what we're doing all the time to our end goal. So, again, if I'm a runner or a sprinter, I need to have that big lower limb strength. If I'm going to be changing direction, I need to be able to get low and to push off. So we're beginning to really tie together the exercises towards our higher functioning phases, our end goal, and our sport demands or our real life demands, depending on what our goals are.
Yeah, and I think even with that idea of progress, it's like hopefully this person's coming back and they're saying, I'm feeling better here. I'm not perfect. I'm not there yet, but I'm on the right road. And what I'll say is, great. We need to keep going down this road. We don't need to change the plan here. That we've clearly got the right problem. We're starting to work the right area. You're starting to see the improvement. We're working over here. We don't take some random jump over there. No. What we do is we make what you're currently doing harder. If it's not broke, we don't fix it. So, okay, your rotator cuff is getting stronger. Is it the strongest rotator cuff in the world? Okay, it's not. But what's the next level? What's the next jump? Can I do a heavier band? Can I change that angle? Can I add in more weights? Do I give you more exercise? Do you do more reps? So how do you progress that in difficulty?
Yeah,
as you've said with the full limb or the full body, the compound movement. It's okay, great. My knee quad extension is only a one joint movement. Let's do multiple joint movements.
Yeah.
As you said with the testing, that's like, what can the other side do?
Yeah.
Well, your other side can do 15 single leg squats. This side can only do 6.
Yeah.
Can you see the difference there? Oh yeah, Mike, I can see the difference there. Okay, you want to run for 4 hours. Do you think you should be the same strength both sides? I should definitely be the same strength both sides. So it's repeatedly, I suppose, speaking back to the patient. How good is good enough is something I know you always say. So, at least as good as the other side. And, us ourselves might have targets for, be it percentage body weight or be it sort of how many reps somebody could do for their sport, for their weight, for their age group, whatever it is. So setting them a general target and setting them a specific sort of interlimb target, I think really, really important. And as you progress that, as you said, it's now we're trying to train a lot of things. And I often say with the initiation phase, it's like you have a really good chance here to load your hamstring lots or load your cuff lots. And it's going to be harder to do this when we're trying to train 10 things. It's easier when we're sort of focusing on one thing. Whereas now we have our strength stream, our power stream, our plyometric stream. We're still doing our rehab stream. And I suppose how we communicate that, how we shape their week, how we write their program. Again, that's invaluable. And maybe that's something that people don't realize when they come to RAPID is like, actually the lads are trying to look after a lot of things here. And they're giving me a plan that allows me to do all these things over the next 2 weeks or 3 weeks or whatever it is.
And I think this is really where our skill set as both physiotherapists and strength and conditioning coaches comes to the fore. Because, what you just described to me there sounds a little more like a strength and conditioning coach almost than a physio. And I think we really believe in the importance of marrying those two skill sets because, if the physio world is guilty of anything, it's probably, traditionally a little bit guilty of doing the low level exercises, but not maybe progressing them sufficiently enough and not bringing in the tenets of strength and conditioning, which is to load the body appropriately with heavy enough load and to progress it. And as you said, Mike, it is that idea of starting to ask the question of how good is good enough? Because again, we've probably seen it a million times. I know I have. I see it every week. Someone who has maybe been doing some exercise and has tried maybe to kind of rehabilitate, maybe with guidance or just by themselves, and they're doing something of value, but they just haven't progressed it sufficiently. So we're really starting to step that up now. And as you said, it's a shift in gears there. It's a change in mindset a little bit where we do start to talk and act as strength and conditioning coaches now, where we're still have one eye on the injury that needs protection and we need to not overload it. And we're still all about facilitating healing and managing pain. But that is now a smaller part of what we're doing. We're focusing now on starting to target that functional piece. And again, to really, I think re-emphasizing that again and again is so important in the gym and coaching people as to how to do their exercises. Because again, this is where we see a lot of a lot of people, when we get back into the gym, it's almost like starting again a bit. You know, we might feel like I'm going well with my isolated exercises, my cuff work or my quad work. You know, I'm going well with that. And then we go into the gym, we say, right, let's do a single leg squat here. And all of a sudden, like the knee doesn't want to move, my hip feels stiff, my ankle's sore, and it's almost like starting again. So what we got to do is we got to coach that. And really, we're not starting again. We're just getting used to something we haven't done in a while. And quite often, I think there can be a little bit of discomfort with those movements. And what do we see around discomfort? Well, we generally see a pattern of avoidance where people will maybe adopt a compensatory pattern. I'll give you an example with a squat. You know, my knee is sore, so what I do is rather than letting my shin move forward, my knee move forward, I tend to sit way back with my hip. And that's great for protecting my knee and, you know, not loading my knee and loading my hip a bit more. But ultimately, where do I need to go? I've got to be able to load this knee again. So we see it classically with the ACLs. You know, the body is resistant to that movement of letting the knee go. And so this is a phase where we're starting to...
It'll take the path of least resistance.
It will, absolutely. And also our body kind of tends to be resistant and guarded and protective here. Subconsciously, we don't even know we're doing it, but we're avoiding it. And does avoidance work well? Generally not in most areas of life. So what we have to begin to do is turn ahead and face it and try to begin to load it and to begin to I think a lot of it there is providing reassurance for people. It's safe to do this. It's okay to feel this way, to feel a little bit of discomfort. And again, we're packaging the exercise in, okay, how do you feel during? It's a little bit of discomfort, but am I okay afterwards and fine tomorrow and my next session is better? Brilliant, let's keep going. And it is a little bit of a balance there where we're trying to find the right level, because of course we can overdo it too. And you know, it's always this balance of we don't want to go too slow, and if we try to go too fast, we might end up going slow anyway. So we're trying to find that middle ground with people and guiding them on it. And that's where the I suppose the art of coaching comes in a little bit, you know, how to do it, what speed to do it, what angle to do it, what load, exactly what way, you know, and there's lots of little nuance around coaching that.
But I think, as you said, the modern physio really is someone who's really good at their anatomy, their physiology, understanding tissue healing, understanding injuries, getting that diagnosis. But the modern physio really has especially working in this sort of setting, the musculoskeletal setting, has a great understanding of the strength conditioning principles. They understand the difference between aerobic training and resistance training with different muscle fiber types, with different joint angles. You know, you need to know the common exercises in the gym, the equipment, how do you load things. And, you know, and really the really good S&C coaches that I know nowadays actually have a really good understanding of injury and rehab. And again, in different settings, these two people are working next to each other. And in some settings like what we have, these two people are one person because we're actually good at both sides. And of course, you might return somebody to their club or to their team here, to their S&C for the very end stage or the on-pitch stuff. But, you know, I think to be good at you know, at our job, you need to have a really good understanding of both. And, you know, with the team we have here, obviously everyone is, and it's something we put a lot of time and effort into. With this progression as well, and it ties back into that point, so many times in the past, I've seen a patient who does one exercise really well and takes a completely illogical step to a next exercise, and then a completely illogical step to another exercise. And there's nothing wrong with any three of these exercises, but they don't follow a clear path of progression. It's not that it was the same thing at a new angle, or it was the same thing a bit faster, or the same thing, you know, a bit stronger. They had no connection to each other. For example, I did my rotator cuff exercise with the band and that felt good. So then I did a one-handed push-up. And then what I did is I did a Turkish get-up. And while there's nothing wrong with any of those exercises, they don't follow a clear next step idea. And what you're saying is, you know, we're on the right road. This is what my sport looks like. It's up here. But I want to go one step at a time. And our job is to guide that patient one step at a time. You know, how many building blocks do we need to get back to our sport? Yeah. Whereas when I just pick something, I saw something online yesterday that looked good, so I decided to do it. You know, it's often not the right next step. And that's where somebody can do something they weren't prepared for and actually set themselves back.
And that's why we have a framework, is ultimately, again, it holds us accountable to logical next steps. And it doesn't mean that we have to do every single step to the nth degree for every person. We need to apply it to the individual. But having that framework to say, well, why am I doing this next? Can we answer why? You know, in our programming, in what we're doing, can we always answer why? And, you know, if you ask why 3 times, you know, as you've said this before, you know, you probably get to the root cause of what's going on. And that's a good habit for us. And I think with our clients, we always need to be saying, this is what we're doing next. Here's why we're doing it. And again, that really instills confidence in the process. And it also makes sure that we're not, it keeps us accountable, that we're not just kind of being lazy or maybe picking things that, don't have a good logic, making sure that we have an appropriate level of progression that's backed up with a clear pathway and a clear plan. And the framework really enables that.
And maybe a clear timeline as well, because, maybe we got the diagnosis in one session and, we might have initiated the tissue work quite quickly. But actually, to get really strong, if this is my ACL and I need to get my quad strong after having a graft there, or if this is, some huge hamstring injury and I need to get my hamstring strong again, I need to progress it, this can take a while. It can take a while to build muscular strength, to build muscle mass, to get back to my pre-injury or pre-surgery levels. So, it's not always going to be quick and easy and simple. This P stage can be, it can be weeks or months depending on the injury.
Yeah, absolutely. And I think we want a timeline and a criteria all the way through. Timeline and a criteria. And when we apply the rapid rehabilitation framework to a joint or a specific injury, which we have done, we have our groin framework, we have our knee framework, we have our shoulder framework, we have that specific criteria-based approach to each phase. And phases can run concurrently, which means, I can still be doing some of my isolated loading while I'm working on my more progressive strength work. But my isolated loading may now become my warm-up as the phase progresses on. We don't have to work on these things absolutely exclusively. We can work on them concurrently, but it's really important that we have a criteria. When am I finished? How good is good enough? So there is a time when I don't need to do these exercises anymore. And maybe I eventually progress into a more standard maintenance performance-based program where, my goal now is just to become the best version of myself as an athlete, or to be able to continue to do all the daily tasks that I want to be able to do. But again, it's having that idea of having a structured framework, having both a criteria and a timeline in mind, because everybody wants a timeline, but the timeline is based on a criteria. And I think it's always important to have that.
Yeah. If this is a 6-week rehab and I sit on the couch for 6 weeks, I'm not going to be any better at the end of it. As you said, it'll take as long as it takes to get the work done.
Yeah. And that's something that I think we always have to explain as well, is that for the best will in the world, a purely timeline-based approach, even if someone does everything right, can sometimes leave us wanting, because we are all different. We adapt different, in different ways. And all of those broad factors that we discussed earlier, such as how well I'm sleeping, my stress, my nutrition, the frequency of my training, whether I do everything correctly with the right technique, my age, absolutely, and all the genetic factors that we can't necessarily account for. All of these things are massively important, and they will change. Like, we could apply the same program to two people, but we recover. One flies it and goes really quick, and one takes 2 or 3 weeks longer. Yeah. And so it's really important again there that we have those clear set criteria, so that we don't say, well, look, 6 weeks has passed, let's let you go, and then you re-injure, and then it feels like the whole thing didn't work. But actually, what we didn't do is we didn't hold you accountable to the criteria, which is really important.
Yeah. And I can think of someone who had their ACL repaired, I think 2 weeks before lockdown hit. Did maybe one physiotherapy session, lockdown hit, and it was like, okay, I'll come into you in a couple of weeks when this thing ends. Of course, it went on a lot longer than we all expected. And then at the 9-month mark, came into me and said, I think I'm ready to go back to sport now. When I assessed the knee, I was like, this actually looks more like you had your operation 2 months ago as opposed to 9 months ago, because time didn't heal this. Time didn't get you ready to play a multi-directional field sport. Through no fault of their own, really. It was, it just wasn't the done thing. If you've someone at home, you didn't want to go to a physio session, or just no one knew what to do. So, time didn't do the job there. As you said, it was criteria based. We hadn't hit our criteria. While that graft was 9 months old, that knee looked like what it should have looked like 2 or 3 months into a normal standard rehab.
Yeah. And time alone is usually insufficient to recover from any major injury. Yes, it helps, and time is certainly, our body's innate healing occurs through time, and it is powerful, but it's not great for restoring our function. It doesn't get us back to be able to do the things we want to do at a high level again.
Well, it can help my pain, but it mightn't necessarily help me be any more prepared for my sport. So it's great. My knee isn't sore right now. Yeah, but does that mean I'm ready to run a marathon or play a football match? Probably not. So it's the rehab that does the prep work, really. We have a diagnosis. We know what's going on here. We have initiated some isolated work, and we're training around that. Then we've progressed them onto their strength work, their kind of compound movements, their maybe some speed work or power work or plyometric work, and we're moving up. We're getting closer to that return to sport, return to chaos, return to everyday activity, what I want to do. What's the next step on my stairs here to get back?
So this phase is called accumulation. And this is where we try to accumulate maximum strength, maximum power, explosiveness, as well as a return to whatever my sport-specific movement is. This could be a return to running. It could be a return to the boxing ring or the MMA mat, or it could be return to, you know, partial change of direction running and kicking if I'm a Gaelic football player, or striking if I'm a hurler. So it's the next phase where we're almost just underneath that return to the chaos of the real world. So again, we're trying to test strength here, and these will be our kind of final strength testing sessions where we have that clear bullseye in our mind of how good is good enough. We got to get that good, and we're testing it. And quite often in this phase, really, it's about encouraging people to push themselves harder than they think they should. In rehab, quite often, again, we've got that the remnants of our old injury are not fully gone yet. We maybe still have some stiffness. There may be some, you know, pain coming and going occasionally. But overall, we're a fair bit away from the acute side of the injury here now. And we're looking at getting back into that high level work. And there can still be that bit of guarding and a bit of fear around loading. And this is a part where we have to really push people now. And the goal again is to remind our clients we want to come back better than we were before as our goal. And again, it's different for an elite athlete here. You know, that level's going to be right up at a high level versus maybe someone who's more sedentary and is just active recreationally. But still, we want to make sure that what we don't do is underdo it. We get up to that high level.
But I think that's a real risk, isn't it, as physios, especially because we're used to seeing people in acute pain that often we're very nice, we're very gentle, it's very slow, it's a real fear of pain. We don't want to do too much. And if we do that at this sort of accumulation phase and we're very low or protective, or we don't want to overdo things, it can be a massive jump to then play my football match or hop into that boxing ring or to do that thing I'm trying to get to. And what we don't want is, we don't want this huge jump up to sport. What we want is to accumulate more and more and more and more and more. And then actually the MMA mat or the football match or the rugby match is a step sideways as opposed to a step up. And, you know, the more we can accumulate here, and as you said, the harder we can push ourselves, and the more our rehab demands can almost mirror our sporting or activity demands, it's a way safer return when we do get there. It's hard when you're doing it, and it's hard to maybe make that jump from 85% to 90 to 95 to 97 to 98 to 100. Hard to get that right. But you're the patient or the person in front of the athlete is way more comfortable, way more confident, you know, jumping off the cliff and hoping that their wings will work, as opposed to if we skip steps and we're too gentle and our S&C minds aren't switched on and we're underloading them, you know, then we're taking the risk. And we've seen it with hamstrings, we've seen it with calves, we've seen people follow the plan repeatedly and fall at that last hurdle. And it's probably because that last hurdle was just too high a jump. They'd sort of jumped one or two hurdles a bit better before it.
Yeah. Yeah. And there's just a different feel to the training sessions and the rehab sessions at this stage. You know, we mentioned in our progression phase how we're working on specific angles and making sure that we're getting back to using the limb as a whole. And yes, we're progressing the load, but there's a lot more detail around, you know, how I'm doing and how it feels. We've initiated things like our plyometrics, our hopping, but we're not telling people to now forget about how you do it. Show me how well you can do it. Show me how powerful you can be. Unleash it now. Can you push as hard as you can? You're not injured anymore is the kind of we're trying to embody that sense when we're training, and it's to push ourselves hard and to try and almost let go of that identity as I'm injured now. I'm trying to restore peak performance now,
preparing myself for battle or for performance.
Yeah.
And at this stage, Risteard, is this done now in the physio room? Is this stage done in the gym? Like, what does this stage look like for the athlete in front of you?
So if I have an athlete in front of me at this stage, I probably have 2 to 3 gym sessions a week, and I'm probably doing 2 to 3 sport specific type sessions. So that might be a running program that is progressive, starting with linear running, progressing into acceleration and deceleration, and then progressing maybe into change of direction based work and building our getting right up to those high speed movements that mimic sport. Or it could be if I'm, you know, a boxer, I've I've done my shadow boxing. I've begun to hit pads.
Okay.
You know, I'm not sparring yet, but I'm working my way towards that. You know.
Yeah, and is it more controlled? Are you saying, right, you know, a normal boxing session, you're doing 5-minute rounds. I want you to start with 3-minute rounds and maybe, you know, add a minute every week or something along those lines.
So the gym and the strength and conditioning based work and the rehabilitation work is a little bit less controlled insofar as we're trying to get people to go for it now. But then in our sport specific, our real world, that's controlled. Where, like, let's say if we're going back to the thing that we injured ourselves doing, maybe it was I injured myself sprinting, or maybe it was I injured myself when I threw a punch, or maybe I injured myself changing direction. That's more controlled now. We're starting to face the devil there and to go back to what we did when we injured ourselves potentially, and we're doing that in a controlled way. But our gym work is more about intent, more about pushing ourselves and more about going for it.
We're approaching max on the gym side of things, and now we're starting to ramp up this sort of sport specific for the GA athlete, the pitch side, or for the boxer, you know, the ring side of things.
Yeah.
And you know, we often think about that chronic exposure. It's like, great, we're back boxing 1 week here, but you know, we previously boxed 10 years in a row without missing a week. So, you know, we're still only at the start of this thing, and you know, whether it's the you know, the average of the previous 4 weeks or 6 weeks or 8 weeks is kind of acute chronic workload ratio. And you know, again, with the data out there, again, if we have a high level GA athlete, we know how many high speed meters they need to hit. We know how many overall meters they cover in a week. So we kind of know this is where we need to get to. And it's great you've done one sprint, but we need you doing 8, 10, 12, 20 of these efforts. So we need you at X amount of meters per second. So I think being data driven here where possible, obviously with more elite athletes, really, really important. But as you said there, starting to accumulate this sport exposure, doing more and more of the thing that injured me in the past, the more and more of the thing I want to get back to. You know, again, this is just the stage people have for 50 years, physio skipped this step because they didn't understand it.
Yeah.
You know, I prepped myself really well in the gym, then I played a football match, and it was a big jump. It was a big risk. Yeah. And I think even for maybe our pitch-based athletes, it's like, no, actually you are training on a Tuesday and Thursday with the team, but I don't want you doing, if you're a prop, I don't want you doing max effort scrummaging. Yeah. Or if you're, you know, a GA athlete, okay, you can do small-sided games because you can't sprint yet, but let's not do this full-sided kick-out drill where you're a midfielder and you're going to have to absolutely leg it after your man and cover X amount of meters. Because again, that's the uncontrolled environment. And I think the nature of the beast is they're all athletes, and they can say, Risteard, I'll go at 80%, but once that ball's there and there's a man beside them, you know, they're not going to hold back. And it's in us, isn't it, to give 100 in that scenario. And that's an unnecessary risk at the start. We have to work towards it.
One of the philosophies that underpins everything we're doing and everything we've discussed is this idea of starting with the end in mind, or beginning with the end in mind. And the idea of we've almost reverse engineered the process where, you know, in that very first session, we've spoke to people about what are the goals, you know, what are the targets. And as you mentioned, we're bringing the data side into that now, where we're saying, well, look, here's exactly what that looks like. What are the numbers? How many high speed meters do I need to hit? How many, what level of strength and power? How quick do my ground contacts need to be for me to be able to perform at a high level, to get back to being as good as I was before I was injured, or better than it, ideally, as our target is. So I think that we've set the stall out where ideally now we're really testing here if we have built our foundation well enough, because this phase, while it requires hard work and it requires intent, it should go really well and be easy and be really enjoyable. You might be tired, but you're feeling like you're back at it now. You're feeling like you're in control. You're feeling empowered because you're really going back to the high level activities that you want to do. And it's always a really good test for us here. Have we got is our foundation sturdy and is it in place? And if it is, this phase usually kicks on really, really well. Of course, you know, with any injuries, there can be ups and downs, and sometimes we have to modify the plan, and the plan's only as good as it can modify it and change based on our response to it. But again, typically at this phase now, we start to really set sail, and we really feel like we're kicking on well.
Yeah, well, I think when this stage goes well, you know, somebody's back on the pitch 2 weeks and say we have a 4-week plan to their first match, and after 2 weeks they go, I think I could play. I feel ready. And that says, great, we've followed the plan perfectly, we've accumulated, we've built that pyramid, but we're still going to follow the plan. Even though you think you can play tomorrow, let's stick to the plan. Let's stick to what we said before, because we're just allowing, you know, these adaptations to take time. We're allowing, you know, these properties to improve and the expected timelines. And kind of as you alluded to there, when this stage goes poorly, it's probably because we've skipped something or we've rushed phase 1, 2, or 3, that we actually haven't built the strength we meant to build. We've fallen off our isolated work, and we're not doing that anymore. And suddenly that little shoulder thing that was, was a big problem. It drove me into Rapid. It's got better, and now it's creeping in again as my load goes up, as my strength goes up, my power goes up, as my sport goes up. And now I'm actually struggling at this accumulation phase. So, I think we need to preemptively warn people before this. It's why we need to tick each box. Yeah, that I don't want you breaking down when we're so close to the finish line. Yeah, because then it's a risk.
Yeah, absolutely. Yeah, and I think because we've had that kind of, let's just take for example, we've had a shoulder stabilization, and we're a rugby player, and we're playing, in the AIL, and we're trying to get back to play at a really high level. I think really a part of our role and why it's helpful to have these phases is, we do really have to shift gears into this really high level output, because if our goal here is to be able to, tackle people running at a full pace, I really have to be robust. And, we've spent quite a bit of time on the lower levels. We've spent quite a bit of time on the activation, on the range of motion, on the motor control, and we've maybe been doing some strength work. But I think having this phase where it's about accumulating maximum strength, maximum power, explosiveness, we have to really shift gears there. And I do think part of our role is to make sure that we encourage people and give them permission to really push themselves now at this level. And yes, we also test there whether we have done a really good job at the lower levels, because this phase should go well if we have done that. But it's that, again, it's a phase shift for people into this idea of maximum effort now, maximum strength-based work, and then starting to try, to begin some of the sport-specific work at the same time.
And what are some of this, you mentioned a rugby player there, rugby was your background, you know what a rugby player needs to do, you understand how the training might go. If you have an athlete playing a different sport, how do you go about helping them this accumulation phase? How do you get them ready for their sport if it's something you haven't played yourself, or maybe even with the boxing and the MMA, it's something you're obviously starting to work in a lot. What are some of the skills you have there to help them?
Yeah, well, look, I think there's basic principles that underpin, what you need to do in all sports, but also knowing your sport is massively important. So, for me, I will always endeavour to actually learn as much as I can about the sport, and it's easy with rugby because I've played it and trained it to a high level. But with 12 years experience working as a physio, there's not many sports you haven't worked at this stage. And what you begin to realise is that there's basic principles that underpin it. And that's why we have the idea of the RAPID Rehabilitation Framework, because there's a core set of principles that underlie everything we need to do. A very simple way is to have a conversation with the athlete. First of all, what exactly is it that you do? What exactly is your injury mechanism? What exactly does your training week look like? What exactly are the drills that you do? Can you show me? Can I look at a video? Can I go and attend? So with some of our more elite athletes, I've gone and attended sessions with them, and you're observing that and you're learning. And to be honest, the principles that underpin it are fairly similar. And if you're a physio working in musculoskeletal medicine as well as elite sport, you're going to be big into sport. You're constantly analysing what the movements are and what the underlying physical attributes required to do the sport. So, if it's a field-based sport, a running-based sport, there's huge parallels between all of those, So again, if you know one, you kind of know them all. Whether it's your Gaelic footballers, your hurlers, or your soccer players, there's huge parallels. Obviously, there's minor differences between them. Yeah, there's huge parallels. And look, it's always an interesting piece when you get someone. Recently, I had a hammer thrower in with me there. And it was the first time I'd ever seen a hammer thrower. But for me, it's something that's a really interesting and exciting thing when you get something that makes you think a little bit outside the box. With him, what we had to do was he was at post shoulder stabilization, and it was a case that, the positions he used to get into are quite unique there. You're over your head with huge rotational based movements, and you need to have really good shoulder range of motion, but also beginning to bring in some of those overhead rotational based movements early on and progressing them. So again, always understanding real detail what's required at the start. And it is our role to go and make sure we know, and we have to find out. If not, if you can't bluff there, you have to go and find out. You have to understand the sport. And, while we're not expected to be an expert in every sport. We need to know enough that we can program appropriately. And if we can't, it is our responsibility to refer appropriately or educate ourselves or go and learn.
But I even think that's having a certain type of analytical mind, that you can look at something like a hammer throw and you can maybe think, okay, what are the speeds involved here? What are the joint angles? What are the major muscle groups? How heavy is it? What is it? Strength? Is it power? Is it speed? How many times do I have to repeat this effort? Do I need to be globally fit? Like, again, these are conversations we're able to have because we're really into it.
Yeah.
You know, it's not maybe a core skill for everyone working in this space, and maybe it makes us a little bit unique that we can, you know, there's loads of people who can't do have these skills, but not everyone does. So to be able to help those really elite athletes, and, you know, I work a huge amount with golfers, and, you know, I say part of that, understanding that golf swing, it's those same skills that allow me to analyze how much does their knee move, their pelvis, their hip, their spine. What does good look like? How can one of those places being a bit stiff or a bit sore affect the other parts? You know, I say it's the root cause. You know, if I go out to the car engine, I take out one part of the engine, I might still drive home, but some other part breaks down. And if I keep fixing that broken part, I keep missing the missing part. So I think having that analytical mind and being able to apply it to one skill or one movement allows you then, when someone comes in with a hammer throw, to apply it to something you've actually never seen before. And, you know, it's invaluable really to athletes and patients to have that, to know Risteard's going to go and really look at this to get me back to where I need to go.
Yeah, I think it creates a lot of buy-in and trust, and it's just being genuine. Like, it's asking yourself, like, what's the best thing for this person? You know, like that's what our role is to try and figure out, you know, what is the best thing we can do? What's the best rehabilitation program we can do? And if we use that as our guiding principle and we ask ourselves, are we doing the best we can here? You know, of course, we need to know about the sport, and we also need to be honest with ourselves if we don't, and we need to go and find out, or we need to ask for help if that's the reality. And yeah, like, people know straight away as well if you're being genuine and you're being honest and you're trying your best with them as well. So I mean, I think that's self-evident, isn't it? So
yeah, it's possibly a side point, but I'm just wondering, even with Sam, if we could maybe organise a Rapid Olympics. I wouldn't mind having a hammer throw off and just seeing which one of us could take home the gold. Would you back yourself on that, Risteard?
We still need to have a race. I don't know, 2 shoulder surgeries.
Yeah,
maybe not the hammer throw. Might be my best.
So the money's on me there. A couple of hamstring strains, you can't do the sprints either.
Yeah, sort of the bionic man there.
It could be an idea for the next staff's outro. Okay, Risteard, right. We've diagnosed them. We've initiated the isolated work. We are progressing their strength, their power, their speed. We are accumulating more of their sport-specific work. How that looks for each athlete is different, for each sport is different, for each position within the sport can be different. Mightn't always be, but it can be. What next? Can I go and play my match? Can I throw my hammer? Can I have my fight? Can I run my, 100-meter finals in the National Indoor Stadium? Okay, what comes after that accumulation phase?
So this phase is our final phase, phase 5. This is our return to chaos phase. And I suppose the underlying principle of this, I think, is really about confidence. And I think, you have to earn confidence. And how you earn confidence is by going and doing the hard thing till it's no longer hard again. And this there's obviously, with the injuries, there's a huge psychological piece to it. I can speak for myself. I've had 2 shoulder surgeries at playing high level rugby. It's difficult to return to tackling 120 kilo ogres running full force at you when you've had 2 shoulder surgeries. It's not easy. And even though you've done the work and
your tackling was always decent, in fairness.
Let's say you've done the work, you've done the rehabilitation, you've done the gym work, but the gym isn't the pitch. And all of a sudden now it's contact, it's collisions, it's, the actual force going through the shoulder. It's me facing the issue again. And again, what does it really involve? It's very context specific depending on the sport. But this is where we think about things like very much functional, sport specific, on-field based activities, and the gym-based activities become much more chaotic. We're looking to overload. Of course, we're still doing our basic strength work, and we may still be doing little bits from each phase here now, but we're bringing in this piece of
you're topping them up. You're making sure they don't get worse. They're less of the overall plan, but let's keep a bit of this, but let's focus on that.
Yes. And let's see, can we overload, like if it's a shoulder, can we overload the shoulder? Can we challenge it in a way that is sport specific? Can we really try to, get it to such a high level with maybe overhead based work or perturbation based work? So we might have, we're doing handstands, we might be doing overhead perturbation work. We might be beginning to do some tackle bag work. We might be doing it while we're tired. We might be repeating it again and again and again till we don't have to think twice about it. And I suppose we're really trying to prepare now for the thing that we need to do on the pitch, and really that's by doing it. And I do think that, again, it's a really important area that is often underdone. You know, we're good in the clinic, we're good in the gym, but are we actually good at helping people transition onto the pitch? And you do need to know your sport, and it is a little bit context specific again. Like if you've got an athlete who's maybe working with a team that has a strength and conditioning coach who you can communicate with, and you know they can help them with this on the pitch, or you yourself would be on the pitch, you know, which I've done many times with loads of athletes, particularly for working with teams. You can be very, very hands-on in this phase, and you know, again, it can be really helpful. And a lot of it is a communication with the player or with the client now as to, you know, what are you worried about? What are we nervous about here? Are we 100% ready?
Yeah.
What's stopping you? When you watch a game, what makes you nervous? What makes you worried? Is there anything here that you're concerned about? Okay, how do we change that? And actually, like, quite often people's natural reaction is, well, I'll try and avoid that. You know, I'll maybe won't try and get myself in that position.
Use the other shoulder.
Use the other shoulder. It's amazing that is often the thing that we're still kind of hanging on to those things a little bit. So I think our job is to say, that's not going to work. We need to try and get to a place where you are really confident in doing it. And there's a little bit of just building up to actually do the thing. You know, do 10 tackles with guys that are bigger than you running full force. And what happens is, you know, you're nervous, and then you realize, I'm fine.
Yeah.
And you progress on. And again, this should be fairly, like, it's not necessarily easy from a psychological perspective for the athlete, but actually the body should be able to tolerate it now. If we've done a good job of everything else, the body's prepped, and there's a trust in that, and we know that, and then it's about just conditioning ourselves to the chaotic demands of the real world. You know, so different angles, different forces, different speeds, doing it while I'm tired. That's really important. And being creative in the gym, you know, doing things to fatigue, getting someone tired before we do our training in the gym. You know, we begin to become much more creative and chaotic, and also just partial training. So, you know, we have a return to contact protocol that we will use if it's rugby or Gaelic football or hurling. And I suppose then we might adapt that differently if it's a Brazilian jiu-jitsu or it's a boxer, you know, and really it's about phasing the impact-based work gradually and progressing it. And again, it's having structure and having a plan. Because you do quite often maybe hear of somebody who, you know, they've done well in the gym, they just, okay, back you go to the pitch, and, you know, they feel at sea, they feel a bit lost, and they maybe feel all of a sudden like, geez, maybe I'm not going to be able to get back. And the stats on this are fairly, you know, they're fairly sobering, which is, you know, particularly if we look at the kind of bigger major surgeries, whether it's shoulder stabilizations or it's ACL injuries, like quite a few people don't get back to the same level of sport, you know. And okay, sometimes people just decide, listen, it's not worth it for me in my life to go through something like this again, and that is understandable to some degree. But also it's highly likely that some people just haven't restored their confidence doing the task again, and haven't really embodied the idea that they're no longer injured, that, you know, their risks now are low, and they're low because, you know, they've built all of these criteria back up to a level where, you know, other than in name, they're not injured anymore. You know what I mean? They've had this injury, but there's no signs of it or findings of it anymore.
Yeah, but I think the key there you started on is that for the confidence, we can't give them confidence by what we say.
Yeah.
Even with our testing, even with their gym scores, even with all the jumping or the hopping or the plyo push-ups, or when we take out the active force or we get them on force debates, none of that gives them confidence like doing the thing. Like making, you know, after they've made 20, 30, 40, 50 tackles, suddenly now that fear goes. And there is always an element of, I have to jump off the cliff here, and I have to flap my wings and I have to fly. And, you know, if we tick every box and we clear every bit of criteria, we're confident in them. But confidence is built by them doing the thing.
Yeah.
And that just takes time. That takes a bit of exposure. And you say it might take you 5 training sessions, or it might take you 2 matches, or it might take you, you know, whatever amount of sparring sessions to really feel confident here.
And it's a really interesting thing as to what's actually happening here. Like, I suppose our nervous systems are wired to protect us. And, you know, oftentimes this injury might have occurred in a rugby tackle, for example.
Yeah.
And as a result of that, you know, that my brain is now wired to protect me from that thing that caused me to have to be out for 5 months and all this hardship and all this. I can't do the thing that I want to do. So our nervous system is naturally wired to guard and protect us against that.
But I think as well, though, I think our nervous system has protected us every step of the way up to now. In that initiation phase, it was scary to lift my hand past this point.
Yeah.
And you gave me my cuff exercise and, that wasn't scary anymore.
Yeah.
And it was scary to do a push-up. So you started me up on an incline and a half rep and suddenly I can do a push-up. And it was scary to do my first throw and my first handstand, everything's been scary up to now.
Yeah.
It's just, I suppose, the risk seems greater when it's the tackle.
Yeah.
And it's just, it's graded exposure.
The risk seems greater, and it is greater.
It is.
No, yeah.
But again, can we grade it? Can we start with tackling someone smaller at a slow pace in a controlled environment?
Yes.
Then can we get the person bigger and bigger? Can we get the speed higher and higher? And then the uncontrolled environment is, I'm stepping that way. They go inside. I have to turn.
Yes.
So that's my scary position.
Yeah.
Do I warm it up really well? Do I tape it? We've all those little things, but until I've made that tackle, it's always going to be at the back of my head. And when I've made 5 of them, I go, oh, Risteard was right.
And Mike, you're just speaking there to like a print. We spoke earlier about, how do you know what to do in a sport? Maybe that's outside of, your comfort zone. And we spoke about the idea of principles that underpin everything that we do. And one of the most core principles is this idea of graded exposure. And that's how our bodies, that's how our nervous systems adapt. That's how we adapt as people. Through graded exposure, we become desensitized to the fear. We do it again, repeat it again, maybe grade it at a lower level initially so that you can earn your confidence back through doing it.
Yeah.
It's all about that. And I think graded exposure is just one of these magical things that works for us when we get the dosage right, when we get the frequency right and all the parameters around it, and essentially just gradually progressing, gradually doing the harder thing, spending time doing it, repeating it again. And the magic is that our bodies and our nervous systems can adapt to that really well.
Big time. And again, like something you've referenced a few times there is can I do it when I'm tired, or can I do it repeatedly? And I think, again, this phase can go wrong where it's, I've done 3 sprints now, I'm going to play a 70-minute match in Crow Park. And actually the amount of meters and the amount of running I have to do there is just different than 3 max efforts. I've made 1 tackle on the biggest guy in the team, so I'll play an 80-minute rugby match, and that can be a jump. And it's how many times do we have to be able to repeat this? Can we do it when I'm tired? Can I do it last play of the game? Can I tackle the biggest guy when I'm wrecked? Can I sprint the length of the pitch in injury time to stop something? And we need to, somebody's almost there. They're almost still a risk until they've played 3 matches. It's great you got through the first one. You came on as a sub and you played half a game. But can you play 2 games in 5 days? And like each demand there changes, and they might need to know, okay, actually I need to dial down the gym and maximize the recovery between these 2 events. And I think talking to them, knowing their sport, knowing how many games I have coming up. If I have a game this Saturday and next weekend's off, great, I can hammer it this Saturday. If I have a game Saturday, Wednesday, Saturday, that's going to be a tougher week. So these are all the little nuances that are, they're patient specific, they're sport specific, but we have to get these right, because we don't want them playing the first match for 40 minutes and then 3 days later playing 80 and wondering why they're sore again or why something's happened.
We've got our five phase. We've gone into it in a bit of detail there. And, when we pull up the protocol in front of our clients, what do we say? And I suppose we've got diagnosis. What's that about? Really, it's about what problem are we solving? Initiation, it's about where do we start? Then we've got progression. How do we start building your overall strength and power? Then we've accumulation. Can we start to maximize your strength and power? And then we've got return to chaos. Can we go into the fire? Can we really progress so that we're, back into those real world demands? And you can talk about each of those phases probably for a couple of hours if we wanted to. But it's nice always to bring it back to that simple kind of, where am I on the journey? Have I got a clear plan? And is there logic behind what I'm doing? And are there core tenets that back this up? And do I earn the right to go to the next level? And that's really kind of the core kind of message behind this whole framework.